Hello students. So today's question was a young female with an anterior neck swelling. The swelling was resected and a histological picture was given to you in which we can appreciate an optically clear nuclei, nuclear crowding, overlapping, grooving. So the correct answer is papillary thyroid carcinoma. Papillary carcinomas, as we all know, they are the most common form of thyroid cancers, accounting for nearly 85% cases of thyroid cancer. The common age group of presentation is 20 to 40 years age group. Females more common than males. The best thing is that they have an excellent prognosis and the route of spread is lymphatic. Papillary thyroid carcinoma, it includes the conventional PTC and the encapsulated follicular variant. This category now includes the newly described lesion known as the non-invasive follicular thyroid neoplasm with papillary-like nuclear features, which is a low-grade neoplasm with such a minimal risk of recurrence that the word carcinoma has been removed from its name. Other subtypes of thyroid cancer are follicular carcinoma, poorly differentiated and anaplastic carcinoma, and medullary carcinoma. The conventional PTC has two defining genetic abnormalities or translocations that result in gene fusions of RET or NTRK and point mutations in BRAF. Now, this is the pathogenesis of all the types of thyroid carcinomas, and in particular if we look at papillary thyroid carcinoma, then we can see that the RET gene and the BRAF gene, they are the most commonly implicated genes when it comes to PTC. The RET gene is located on chromosome 10 and encodes an RTK, that is receptor tyrosine kinase, which is normally not expressed in thyroid follicular cells. So this PTC rearrangement involving the RET create fusion genes which encode constitutively active forms of RET tyrosine kinase. So there are more than 15 fusion partners of RET and two designated PTC1 and PTC2, which are most commonly observed in the sporadic papillary cancers. Then there are paracentric inversions or translocations of NTRK1, another gene which encodes receptor tyrosine kinase on chromosome 1 and are present in about 5% of PTCs. These rearrangements also produce the constitutively active NTRK1 fusion proteins. The other gene is the BRAF gene. So between 50 to 80% of PTCs, they harbor gain of function mutation in the BRAF gene. Most commonly, a valine to glutamate change in codon 600 are noted. In a subtype of the conventional PTC, which is known as the tall cell variant, BRAF V600E mutations are virtually diagnostic. Now, environmental factors, the most important risk factor which predisposes to thyroid cancer is exposure to ionizing radiation, particularly during the first 2 decades of life. And to prove this as a corroborative evidence, there was a marked increase in the incidence of conventional PTCs among children who were exposed to ionizing radiation after the Chernobyl nuclear disaster in 1986. Morphology: grossly conventional papillary carcinomas, they may be solitary or multifocal. They are usually well circumscribed, grey-white, and while others infiltrate the adjacent parenchyma and have ill-defined margins. The tumors may contain areas of fibrosis and calcification and often cystic. The cut surface sometimes reveals the papillary foci which point towards diagnosis. Microscopic hallmarks, very important as pathology students. There are branching papillae, जिससे इसका नाम papillary पड़ा है, which have a fibrovascular stalk. Any true papilla will have a fibrovascular stalk and an arrangement of cells around that fibrovascular stalk. इस arrangement को हम papilla कहते हैं, true papilla. इसी से इसका नाम papillary thyroid carcinoma है. So covered by a single to multiple layers of cuboidal epithelial cells, The epithelium covering the papillae, they consist of well differentiated, uniform, orderly cuboidal cells. At the other extreme are those with anaplastic epithelium showing considerable variation in cell and nuclear morphology. When present, the papillae differ from those seen in areas of hyperplasia in being more complex and having dense fibrovascular cores. Diagnostic nuclear features, please note down very carefully. They have nuclei with finely dispersed chromatin, number 1. Number 2, they are optically clear or they have an empty appearance, जिससे इसका नाम पड़ा है orphan annii nuclei in honor of the popular comic character Little Orphan or Little Orphan Annie who had empty eyes. उसको देख के इसका नाम orphan annii nuclei पड़ा है. In addition to invaginations of the nuclear membrane may give the appearance of nuclear inclusions. So, the second most important feature is nuclear pseudo inclusions. So, first is optically clear nuclei, second is pseudo inclusions or grooves. And so, even in the absence of papillary architecture, if we are seeing these features, optical clearing, grooving, pseudo inclusions, we can label it safely as papillary thyroid carcinoma. So, this is the classical picture of the orphan annii nuclear. Here you can appreciate the little orphan Annie who had empty eyes and a dog, and in keeping with this, if you observe carefully the nuclei, they have an optical clearing, so they appear empty. Apart from that, we can see that there is nuclear crowding, there is nuclear overlapping, and if you look carefully, there is nuclear grooving, there are grooves in the nuclei. Now, these are nuclear pseudo inclusions. Look carefully on these nuclei. You can see very tiny eosinophilic inclusions. One is this, one is this. These are nuclear pseudo inclusions, an important feature. In this picture, you can appreciate the nuclear crowding, okay, nuclei one upon other, what is called nuclear molding, nuclear overlapping, crowding, grooving. These are classical features, enlargement of nuclei, these are classical features of papillary thyroid carcinoma. Here you can see the Samoma bodies, another important feature of PTC. Rather, Samoma bodies are often asked in your viva. So, wherever there are papillary carcinomas like papillary serous carcinoma of ovary, papillary thyroid carcinoma, the Samomatous meningiomas, these have the Samoma bodies. So, here you can appreciate the concentric calcifications, they are Samoma bodies. Again, you can see the various stages of formation of Samoma bodies. So, this is on cytology, which is an important diagnostic tool for diagnosis of papillary thyroid carcinoma based on the Bethesda system of reporting thyroid cytopathology. You can see nuclear clearing, overlapping and crowding and nuclear grooving. The variants, follicular variant of papillary thyroid carcinoma has the characteristic nuclear features, almost totally follicular architecture. The encapsulated follicular variant that of papillary thyroid carcinoma without capsular invasion are designated non-invasive follicular thyroid carcinoma with papillary-like nuclear features. So, whereas invasive tumors are referred to as invasive encapsulated follicular variant of papillary thyroid carcinomas. The second variant is the tall cell variant, in which the columnar cells have intensely eosinophilic cytoplasm. These tend to occur in older individuals and they have higher frequency of vascular invasion. The diffuse sclerosing variant occurs in younger individuals, has a prominent papillary growth pattern intermixed with solid areas containing nests of squamous metaplasia. There is extensive and diffuse fibrosis which gives its name diffuse sclerosing variant. Clinical features, they mostly are asymptomatic. Many a times they present only with a cervical mass, that is a cervical metastasis, which might be the first manifestation. Interestingly, the cervical nodal metastasis does not change the overall prognosis. Sometimes hoarseness, cough, dyspnea may suggest an advanced disease. Variety of tests have been used to diagnose and to separate benign from malignant nodules, including radionuclide scanning and FNACs. They have an excellent prognosis, so much so that even lobectomy alone might suffice, and typically they do not require total thyroidectomy. Now, this has become especially important because thyroidectomy may lead to vocal cord palsy and iatrogenic hypoparathyroidism. So, between 5 and 20% of patients with typical PTC, they have local or regional recurrences, and 10 to 15% have distant metastasis. So, the prognosis depends on various factors like age, which is less favorable in patients more than 40 years, and presence of extrathyroidal extension and distant metastasis. So, this is all about the papillary thyroid carcinoma. Remember, the most important features are the nuclear features, that is nuclear enlargement, nuclear grooving, then optically clearing, then overcrowding, and nuclear pseudo-inclusions. So, remember these important points and don't miss orphan Annie-I pattern or orphan Annie-I appearance of optically clear nuclei or nuclear features in PTC. Thank you so much.